Hello, my name is Katrina Burchell. I'm the Chief Executive Officer of the charity, or as you might call it, the not-for-profit organisation called the Pernicious Anaemia Society. I was diagnosed with pernicious anemia nearly 20 years ago, and like many, I've had a very difficult journey through the healthcare profession with this condition. I am neither a medic nor a scientist, but I am a well-researched and informed patient, and I'm involved with numerous organisations including Club 12, an international research organisation focusing on B12, and the B12 Alliance, an alliance of patient-led organisations with a mission to improve accuracy of information and support research, and of course the Pernicious Anemia Society, who I represent today. The Pernicious Anemia Society has been around for 17 years, and its mission is to improve the diagnosis and treatment of pernicious anemia. Based in Wales in the United Kingdom, we have members from all over the world. Our membership currently stands at over 8,000, and the Health Unlocked Forum on pernicious anemia, which we host, has over 30,000 users. Unfortunately, these members and users continually to tell us that the diagnosis and treatment of pernicious anemia is not working optimally for the patient. This is due to inaccurate tests available for B12 serum and active B12 and intrinsic factor, and it's also due to misinformed healthcare professionals who are lacking in training about B12 deficiency and in particular about pernicious anemia. Of course, we acknowledge that there are also challenges in diagnosing this condition, as symptoms often overlap with other conditions. We are the only charity representing specifically the needs of patients with pernicious anemia. There's been a rising interest in B12 deficiency and a growth in the number of organisations and charities looking at both dietary and non-dietary reasons for B12 deficiency. People can have a B12 deficiency, for example, if they've had stomach surgery or an infection like H. pylori. The goals of the charity are to improve the lot of the patient through lobbying for change. For example, the Pernicious Anemia Society was instrumental in getting the UK to draft new guidelines on B12 deficiency, which are due to be published in January 2024. We raise awareness and educate both patients and healthcare professionals all over the world by providing research-based, doctor and scientist reviewed help sheets, training manuals, videos and information. We also support our members and potential members with a telephone helpline service and an email support staffed by trained and knowledgeable people. Our goal here is to provide the relevant information to patients so that they can have constructive conversations with their healthcare provider. Most importantly, in my view, we prioritise, commission and help fund research into pernicious anemia and B12 deficiency, and our members are a reliable cohort for this research. It's useful to recap here what pernicious anemia is. It's an autoimmune disease, and people with autoimmune diseases often have more than one. People with pernicious anemia also often have thyroid issues such as Graves' or Hashimoto's. They may have vitiligo, iron deficiency or autoimmune gastritis, for example. It isn't always called pernicious anemia, but that's what it's called here in the UK. It isn't really the right name for the condition. Most patients do not actually get to the stage of megaloblastic anemia, but the word anemia often gets them directed to haematologists. Most patients in our experience and with our research present with neurological symptoms first: brain fog, confusion, pins and needles, all classic symptoms of B12 deficiency. But the truth is that pernicious anemia is a gastric problem. It fundamentally means that people cannot absorb B12 either at all or efficiently, and it's not curable. But with proper treatment and monitoring, pernicious anemia patients could and should live a normal quality life. Nobel Prize winners found the treatment of B12 injections back in the 1950s, but there has been no significant improvement for the lives of pernicious anemia patients since then. In fact, I would say it's worse now due to the current attitudes of many in the primary and secondary care. In most countries, patients will present with symptoms to their primary care provider. In the UK, diagnosis and treatment fall within the primary care responsibility. Referral is inconsistent, and once in secondary care, it is pot luck whether the haematologist, gastroenterologist or neurologist has any knowledge or experience of this condition. Responsibility for appropriate treatment is often batted back and forth between specialist and general practitioner. The Pernicious Anemia Society has always been at the forefront of research into this area. In 2020, the Pernicious Anaemia Society started on a journey with the James Lind Alliance to look at the patient priorities for research. This process involved a first survey to identify questions relating to the cause, diagnosis, treatment and management of pernicious anemia. A literature search then checked whether any of these questions had already been answered. A second survey asked respondents to identify and rank their top 10 questions from the list of questions from the first survey, and then an online workshop was used and used an adapted nominal group technique to agree a final top 10. Those involved in the workshop were patients, healthcare professionals and researchers. In the first survey, 933 people submitted 3,480 responses, and these were categorised and summarised to generate a long list of 40 questions. None of these questions had been answered by previous research. The combined rankings from the 1,068 patients, carers and clinicians who took part in the second survey identified a short list of 16 questions. These were discussed at the final workshop and agreed the final top 10. The top 10 uncertainties were published in December 2021. The number one question was about an accurate and reliable diagnostic test for pernicious anemia. You may know that back in the last century, the test was the Schilling's test, which is now no longer used, and the current test for intrinsic factor or intrinsic factor antibodies is only reliably accurate in around 40 to 50% of cases. Having a negative intrinsic factor test does not mean that you don't have pernicious anemia. The other 9 questions were about making treatment safe and effective and understanding why people with pernicious anemia vary in their need for treatment. There were also questions which refer to links to other conditions and how to encourage clinicians to take pernicious anemia seriously and provide long-term care. Addressing any of these questions will greatly benefit the end users of this research, the people whose daily lives and decisions will be directly affected by generating quality research and evidence. Perhaps importantly for this audience, 2 questions concern the long-term treatment and monitoring. See questions 9 and 10 in the list. But also importantly, in my view, it brought to light research and practice that was already known but is not actually being followed to the detriment of patients. What is missing is knowledge, compliance with existing guidelines and a proper system of monitoring people with pernicious anemia, particularly in the area of gastric cancer. So why should you care about this? Despite gastric cancer being responsible for a high number of deaths and new cases per year, and notwithstanding that there already exists a recommendation for more screening, there is currently substantial misdiagnosis and underdiagnosis in both of the high-risk individuals, more of them later, and the cancer themselves, with the majority of patients being diagnosed at stage 3 or 4, by which time the 5-year survival rate has dropped from 65% to less than 25%. Despite there being recommendations for monitoring throughout the system in the UK, our members report that this just does not happen. In other countries, we have similar feedback. Even if I were to remove the emotional side of patients wanting a better quality of life, increased survival rates, etc., and we focus only on the economic reason for monitoring, it's hard to justify why a less costly and minimally invasive gastroscopy at a regular period, which would catch the potential of NETs or gastric cancer flags at an earlier stage, would not be considered compared to cancer treatment, surgery and costly palliative care. When it gets to stage 3 or 4, the cancer is metastatic and is usually spread, and the treatment for this is palliative rather than curative. At stage 1, 65% will survive their cancer for 5 years or more. This drops to 35% at stage 2 and 25% at stage 3. In stage 4, there are no 5-year survival statistics. This is because, sadly, most people don't live that long after diagnosis, and 20% with stage 4 stomach cancer will survive their cancer for 1 year after diagnosis. So why should the patient care? With those poor survival rates, the patient's agenda is therefore more obvious, but the late diagnosis also significantly impacts on their quality of life and confers a substantial emotional burden. Given this picture, you may be surprised to know that we actually do know who the high-risk individuals are. And in fact, if you have any of the related conditions of chronic atrophic gastritis, pernicious anemia or autoimmune gastritis, you have a between 3 and 11-fold greater risk of developing gastric cancer. So back to the James Lind Alliance and 3 of the top priority questions in particular. Our research clearly shows that healthcare professionals fail to take pernicious anemia seriously. We don't yet know why this is, but we do know that there has been less and in some cases no focus on training on this condition. There is little available in terms of ongoing training, and there is, as I said, inconsistency in the referral system from primary care, with no single discipline being responsible for pernicious anemia, or in fact B12 generally, B12 deficiency in general. In the Netherlands, the B12 Institute at the Erasmus University Hospital takes referrals from their primary care GPs, and the B12 Institute are the experts in the treatment of people with B12 deficiency resulting from malabsorption issues, including pernicious anemia. People want to know about their condition, what their risks are, what they can do to minimise these risks. Would better and more consistent treatment of their B12 deficiency symptoms reduce the risk of gastric cancer? Are some people with pernicious anemia more prone to gastric cancer than others? Could dietary and environmental factors also play a role? What about familial clustering, something we know is common in pernicious anemia? And with other autoimmune diseases again, we already know it's common to have more than one autoimmune disease. Is there a link here? We know that chronic inflammation increases risk of cancer and that chronic inflammation is common with autoimmune diseases. What signs should patients with pernicious anemia be on the lookout for, especially relating to their stomach and digestive system? As I've mentioned before, many people with pernicious anemia report neurological symptoms first, and if these are resolved or better controlled, they and their doctors may not connect gastric symptoms with their condition without better education and awareness. Let's look at an example of one of our members' experiences in the UK. This patient's experience is typical. There has been no routine monitoring beyond having an initial endoscopy at the time of diagnosis. 7 years on, this patient still complains of IBS, flare-ups, and has a reported increase in tolerance of certain foods and drinks. This patient is also iron deficient and is female, perimenopausal, and has experienced gaslighting by the medical profession, again so often reported by our members. So what do we know already about gastric cancer and pernicious anemia? Well, as I mentioned, Club 12 was formed in January 20 to facilitate the sharing of knowledge and coordinate research into vitamin B12 between scientists and healthcare professionals. There's over 150 members and it's growing. They meet by Zoom every 2 weeks. The objectives of this organisation are to stimulate discussion on the uncertainties surrounding vitamin B12, to promote and encourage research into all aspects of vitamin B12 metabolism, and to encourage multidisciplinary conversations about vitamin B12. They disseminate research findings to clinicians and the wider public. Within Club 12, there's also a pernicious anemia groups focusing on the issues specific to that condition. We already know that some of the research is around gastric cancer and pernicious anemia. We know that there's an increased risk. For other cancers, we know that increased monitoring reduces risk. Think breast cancer and cervical cancer, for example. We know that early detection of cancers improves survival rates. We know that it's important to look at the frequency of the cancer, the severity, the accuracy, the reliability of screening and detecting, the effectiveness of early detection, the risk or harm attached to screening and the cost, and to compare these with the benefit to the population. We also know that gastric cancer symptoms are difficult to detect in the early stages, and we also know that gastric cancer is more common in males, whereas pernicious anemia is more often diagnosed in women than men. Having said all of that, I'm led to the question why people with pernicious anemia, especially if they are high risk, are not already being routinely monitored. suggestions for screening are out there and they show positive results where they have been adopted. But currently the UK does not have a universal screening policy to implement this. The international guidelines recommend screening every 3 years. Although NICE, in their current consultation on B12 deficiency, you'll remember that I said the Pernicious Anaemia Society was instrumental in getting those guidelines drafted, have acknowledged that there is a research gap and this is in need of urgent attention. There are other limitations to the current draft NICE guidelines, but that's a subject for a whole other presentation. Interestingly, in the UK General Practitioner notes, they do recommend an initial gastroscopy. They also say that referral to gastroenterology is recommended if there are symptoms or risks such as coexisting iron deficiency. But we know that none of our members are given information leaflets about what to look for, when to go back to their doctor or when to be concerned. They rely on organisations like ours or on the dreaded Dr. Google, which is unhealthy for both patient and doctor alike. So what should be done? As a patient, my ideal world would include raised awareness for the patient of what symptoms to look out for and what to report to their doctor. This type of advice should come from gastroenterology, in my view, after the initial check. But remember, at this point, the patient is likely to have cognitive issues from B12 deficiency, so leaving an appointment with a discussion and no leaflet or no follow-up is frankly useless. Routine discussions of changed circumstances, particularly with gastric symptoms with primary caregivers, should happen, and a referral to gastroenterology alongside the baseline examination for diagnosis should also have follow-ups at a defined period according to the risk. So let's recap. The Pernicious Anaemia Society's research with the James Lind Alliance revealed that patients wanted to know why their condition was not taken seriously, why it was misunderstood, and why there was no routine monitoring or follow-up, why some people require more frequent treatment than others, and whether or not they should be routinely checked for gastric cancer, which they have an increased risk of because of their pernicious anemia. Our research also shows that our members are not informed or routinely monitored. Research in other areas shows that early detection improves prognosis. So logic demands that early diagnosis and treatment would lower overall healthcare costs and improve quality of life. The Pernicious Anaemia Society has a number of research projects it is involved in and we support. For example, we're looking at what healthcare professionals already know, one of the questions that came out of the James Lind Alliance research. A first look at the results of the research from the De Montfort University here in the UK would suggest that what healthcare professionals have indicated their knowledge and experience is, compared to what they do actually know, leaves rather a scary gap for those of us with the condition. The symptom tracker study by the University of Surrey will also help identify patients with gastric symptoms and how these are affected by frequency of treatment. As I said at the beginning, the symptoms of pernicious anemia fall into different areas. In addition to the ones we've described, they can also present as urological conditions, fertility issues and mental health. B12 deficiency is increasing because of plant-based diets and depletion by other drugs including PPIs, metformin, nitrous oxide, contraceptive pill, HRT. But the gap between knowledge in research and education in healthcare is still too wide. Thank you for listening to the patient advocate point of view from the Pernicious Anaemia Society. As responsible, knowledgeable, informed patient representatives, we want to work constructively with the healthcare profession on raising awareness, commissioning quality research and improving the lives of patients with pernicious anemia. As a society, we welcome membership from healthcare professionals who are interested in this condition. It's free for you and you'll be kept up to date with our research. You can sign up or make inquiries through our website. Of course, I'm also willing and available to answer any of your questions now.